Diabetes represents one of the most pressing health challenges facing elderly populations globally and stands as a cornerstone issue within the broader landscape of non-communicable diseases. As our world experiences unprecedented demographic shifts with rapidly aging populations, understanding and addressing diabetes in older adults has become an urgent priority for healthcare systems, policymakers, and communities worldwide. The question of what constitutes normal blood sugar levels is perhaps the most fundamental inquiry patients and their families make when confronting diabetes. For individuals without diabetes, fasting blood glucose typically falls between 70 and 100 milligrams per deciliter. However, the picture becomes more complex when we consider people living with diabetes. Healthcare providers generally aim for pre-meal blood glucose levels between 80 and 130 milligrams per deciliter, with post-meal readings ideally staying below 180 milligrams per deciliter. Yet these targets are not universal, particularly when treating elderly patients. The aging process brings with it unique vulnerabilities, and older adults face heightened risks from episodes of low blood sugar, known as hypoglycemia. Consequently, physicians often establish more lenient glycemic targets for their elderly patients, recognizing that the dangers of blood sugar dropping too low may outweigh the benefits of maintaining tighter control. Understanding glycated hemoglobin, commonly referred to as HbA1c, is essential for anyone seeking to comprehend diabetes management comprehensively. This remarkable blood test provides a window into the past 2 to 3 months of glucose control, offering clinicians and patients alike a valuable perspective that transcends the moment-to-moment fluctuations captured by daily fingerstick tests. The science behind HbA1c is elegant in its simplicity. Glucose molecules in the bloodstream attach themselves to hemoglobin proteins within red blood cells through a process called glycation. Because red blood cells typically survive for approximately 3 months before being replaced, measuring the percentage of glycated hemoglobin reveals the average blood sugar environment those cells have experienced throughout their lifespan. For most adults managing diabetes, healthcare providers recommend maintaining an HbA1c level below 7%. However, when we turn our attention to elderly patients, this approach reveals its limitations. Older adults often benefit from more relaxed HbA1c targets, typically ranging between 7.5 and 8.5%, reflecting the unique risk-benefit considerations in geriatric diabetes care. The cornerstone of diabetes management extends far beyond medication and monitoring into the realm of nutrition and dietary choices. A thoughtfully constructed diabetes diet must accomplish multiple objectives simultaneously: controlling blood sugar levels, ensuring adequate nutrition, maintaining healthy body weight, and fitting realistically into the patient's lifestyle and cultural context. Vegetables, particularly non-starchy varieties, form the foundation of an optimal diabetes diet. Leafy greens such as spinach, kale, and lettuce offer abundant vitamins and minerals, while contributing minimal carbohydrates. Cruciferous vegetables including broccoli, cauliflower, and Brussels sprouts provide fiber and nutrients that support overall health. Whole grains represent another important category. Unlike refined grains that have been stripped of their fiber and nutrients, whole grains retain their bran and germ, resulting in a slower, more gradual impact on blood glucose. Oats, quinoa, brown rice, and barley provide satisfying alternatives to refined white rice and bread. Protein sources deserve careful consideration in diabetes meal planning. Lean proteins including skinless poultry, fish, and plant-based options like legumes and tofu support muscle maintenance without contributing to blood sugar elevation. Fatty fish such as salmon, mackerel, and sardines offer the additional benefit of omega-3 fatty acids, which support cardiovascular health. Healthy fats play an essential role despite decades of misguided advice to avoid fats entirely. Sources of unsaturated fats including olive oil, avocados, nuts, and seeds support satiety and contribute to cardiovascular health. Understanding which foods to limit proves equally important. Refined carbohydrates including white bread and pastries cause rapid blood sugar spikes. Sugar-sweetened beverages represent perhaps the worst offenders, delivering concentrated doses of rapidly absorbed carbohydrates. The timing and distribution of meals throughout the day significantly influences blood sugar control, with smaller, regular meals helping maintain more stable levels. When we examine the burden of non-communicable diseases in elderly populations, diabetes emerges as a dominant force driving morbidity, mortality, and healthcare utilization. The aging process itself creates vulnerabilities that increase both the likelihood of developing diabetes and the complexity of managing it effectively. Insulin sensitivity typically declines with age, meaning older adults' bodies become less efficient at utilizing this critical hormone. Physical activity levels often decrease as people age due to mobility limitations, chronic pain, or fear of falls. This reduction in activity promotes weight gain and further impairs insulin sensitivity. Many elderly individuals contend with multiple chronic conditions simultaneously. Diabetes rarely exists in isolation among older adults, but instead typically coexist with hypertension, heart disease, arthritis, and chronic kidney disease. This multimorbidity complicates treatment, as interventions for one condition may affect others. Polypharmacy, the concurrent use of multiple medications, represents both a consequence and a complicator of diabetes in older adults. Managing diabetes often requires several medications, and when combined with treatments for other conditions, elderly patients may find themselves taking numerous different medications daily. This complexity increases the likelihood of medication errors, adverse drug reactions, and interactions that compromise efficacy or safety. Cognitive decline, ranging from mild impairment to dementia, affects a substantial proportion of elderly individuals and poses profound challenges for diabetes self-management. Successfully managing diabetes requires remembering to take medications, monitoring blood sugar, recognizing symptoms, making appropriate food choices, and responding appropriately to readings. As cognitive function declines, these tasks become increasingly difficult or impossible without substantial support from caregivers. The consequences of poorly controlled diabetes in older adults extend across multiple organ systems and dramatically impact quality of life. Cardiovascular disease represents the leading cause of death among people with diabetes, and the risk increases with age. Diabetes accelerates atherosclerosis and promotes heart attacks and strokes. Kidney disease develops insidiously in many people with long-standing diabetes, with the kidney's delicate filtration structures sustaining damage from years of elevated blood sugar. Vision problems ranging from cataracts to diabetic retinopathy threaten independence and safety. Neuropathy, or nerve damage from diabetes, commonly affects the feet and legs, causing numbness and pain while diminishing the ability to feel injuries. This dangerous combination means elderly individuals may develop serious foot wounds without realizing it, and impaired wound healing allows minor injuries to progress to severe infections. Hypoglycemia represents a particularly dangerous threat to elderly individuals with diabetes. Blood sugar levels can drop too low for various reasons, including medication timing errors, skipped meals, or unusual physical activity. Elderly individuals often experience blunted warning symptoms, progressing directly to severe hypoglycemia with confusion, loss of consciousness, or falls before recognizing the problem. Falls resulting from low blood sugar commonly cause hip fractures, a potentially life-altering injury in elderly populations. Given these multifaceted challenges, managing diabetes in elderly populations demands a comprehensive, individualized approach. The first principle involves establishing appropriate glycemic targets that balance benefits and harms for each individual. A healthy, active 70-year-old might appropriately aim for relatively tight control, while a frail 85-year-old with advanced heart disease and early dementia requires substantially more relaxed targets prioritizing safety and quality of life. Medication selection in elderly diabetics requires sophisticated clinical judgment, with careful attention to drugs that cause hypoglycemia or affect kidney function. Social support emerges as a critical factor in successful diabetes management among elderly individuals. Many older adults live alone, and social isolation compounds the challenges of managing a complex chronic disease. Family members can assist with medication management, blood sugar monitoring, meal preparation, and transportation to medical appointments. Community resources, including visiting nurses, home health aides, and meal delivery services, become invaluable for those without family support. Looking forward, the challenge of diabetes in aging populations will intensify as demographic trends continue. Globally, the proportion of people aged 65 and older is growing rapidly. Prevention efforts must adapt to address elderly populations specifically, with secondary prevention seeking to prevent or delay complications in those already diagnosed taking on greater importance. Research specific to diabetes in elderly populations remains insufficient despite the magnitude of the problem, and we urgently need studies addressing optimal glycemic targets, medication effectiveness, and approaches to maintaining quality of life while managing diabetes in the context of multimorbidity and declining function. Addressing diabetes as a major component of the non-communicable disease burden in elderly populations ultimately requires a multifaceted response spanning individual clinical care, family and community support, healthcare system innovation, and sustained research investment.